This program is brought to you by Emory University.
Morning, everyone. Welcome to Cardiovascular Grand Rounds. This morning we're going to have a little more in our series of clinical EP. Mikhael El-Chami is with us today, and as you all know, he's a member of our division. Is part of very valuable part of our strong connection with American University in Lebanon, and did his residency, fellowship, and EP training here, and has been on faculty ever since. Mikhael is in addition to being a gifted clinician and educator, is also very focused on his clinical research activities, and I think he's going to talk to us a little bit about some of that today and his interest in subcutaneous ICDs. Welcome.
Thank you. So as Dr. Taylor said, I'll be discussing the subcutaneous ICD. I'll try to stick to a 45-minute or less lecture because I think 1 hour is too long for any kind of lecture. This is my disclosure slide. This is the outline of my talk today. I will start by reviewing the evolution of the transvenous ICD. Then I'll review the available data on subcutaneous defibrillator used for sudden cardiac death prevention and present some of the data from our group. And at the end, analyze the pros and cons of subcutaneous defibrillator. Transvenous ICD is currently the primary device used for prevention of sudden cardiac death. It has proven its safety and efficacy during 3 decades of use in over 1 million patients. The transvenous ICD evolved significantly over the last 20 years, with the first human implant in 1980, FDA approval in 85, then the FDA approval of the first transvenous lead, followed by CRT approval in 2002. And the man behind progression of defibrillator or evolution of defibrillator is Michael Mirowski, who's actually is a very interesting person. He was born in Warsaw, Poland, and had to endure the hardship of World War II. At age 15, he had to escape from the German invasion, and he left to Russia, where he escaped the German from one village to another. Unfortunately, his parents were stayed in Poland and died during World War II. He returned to Poland, where he started med school around age 18 or 20. And then he didn't like education there, so he wanted to go to Western Europe. He actually moved to France, where he finished his med school, even though he didn't know a single word of French, which was amazing. And he worked between Israel and the US. He had to work as a cashier to fund his residency. And then in Israel met his mentor, who was diagnosed with ventricular tachycardia and had recurrent VT and died. So he was very frustrated and wanted to come up with a device for prevention of sudden cardiac death. And when he moved back to Baltimore, he met this physician who works in an animal lab, and together they formed the first defibrillator. This is one of their original models. You can see the Duracell batteries, and they designed it in a basement of the hospital. When he published his first paper, which is Standby Automatic Defibrillator in 1970, this paper was rejected by many journals, finally published in the archives. They tested the first defibrillator on a dog. At that time, an engineer who owned a small engineering company was very interested in the device, so he wanted to fund more studies, so they got more funding until 1980, where their seminal paper was published in New England Journal, where they presented a case series of 3 patients who received the first implantable automatic defibrillator. This is their original model. You can see the sketch, how they designed it. Again, if you're not an engineer, or might not understand it, but I'm sure if Dr. Langberg was here, he'd probably have something similar in his basement. And this is how the original model is. You can see the crude nature of the original defibrillator. And then the first implantable defibrillator came out. It was large, almost a little bit more than half a pound. Required a cardiac surgeon to place epicardial patches and epicardial lead, and had to be placed in the abdomen. And defibrillator progressed as to what we know it now, from an abdominal device requiring cardiac surgeon to the transvenous lead tunneled to the abdomen because these devices were large, and then to the ICD like we know it today, placed in the prepectoral area with a lead inside the RV. And this is from one manufacturer. You can see the progression of the defibrillator progressed from 200 cc's to 39 cc's, so more than 70% decrease in volume. And despite getting smaller, it had a longer battery, the ability to pace, either backup pacing or anti-tachycardia pacing, the ability to have some heart failure diagnostic, anti-tachycardia pacing in the atrium. So they're really such an amazing progression of the defibrillator over the last 20 or 30 years. But along the way, there was multiple setbacks, mainly related to the presence of an endovascular lead. But there's been problem with lead failures due to recalled leads or due to wear and tear. There's been problem with endovascular infections which are associated with a very high mortality. Problems with venous occlusion, which precluded upgrade. Also, there's been a very large ICD generator recall in the mid-2000s, which was a really big problem. And there's other problems such as inappropriate shocks. So I'll present two cases to you that we've encountered in clinical practice that might illustrate problems with a defibrillator. The first case is the case of a 25-year-old man I met in 2011. He was diagnosed with long QT2. He presented with syncope, had genetic testing along with his family, had long QT2. At that time, they decided not to give him a defibrillator and decided to wait. One day, he was leaving his middle or high school and had an aborted sudden cardiac death. Luckily, there was a defibrillator, and he was resuscitated and received his first transvenous ICD, which was an abdominal generator. Had two generator exchanges, one in 2003 and one in 2009. He only had a single appropriate ICD shock in 1998. Since then, he's done really well on nadolol, which is the typical treatment for long QT2. He moved from North Carolina, where he used to be followed at Duke University, and moved to Atlanta. And then I met him to establish care, and then the first time we checked his device, there was evidence of lead failure. There was noise reproducible by pocket manipulation and spike in his lead impedance. So at that time, we had a 25-year-old, had an ICD lead that has failed. We had a long discussion with him. His parents got involved. We had so many phone conversations. They flew in. Their physician from Duke called my chief, called Angel, and they wanted Leon to do it, but Leon supported me and ended up doing the procedure after so many discussions with the family. Had a laser extraction under general anesthesia. It was a really extremely difficult case, required a high 16 French laser sheath. And luckily, the patient did really well. The lead was removed, new lead was placed in. These were one of the cases where, you really grow 2 years older in 2 hours. And I guess the family noticed it, and they sent this nice email, and they CC'd Angel on it. But then I didn't realize that they really realized how difficult the case is, and they mentioned my drenched surgical gown, told us that this task and the entire procedure were not easy. And these cases, up till now, after 8 or 9 years in practice, these are probably the only cases when I still have some concerns. While this case had a good ending, some cases really don't have good endings. And this is the example of a second case, who's a 72-year-old with dilated cardiomyopathy, had a single lead ICD placed in 2005. End-stage renal disease on hemodialysis that developed after receiving the ICD. Had a lead recalled which fractured. And she was deemed very high risk for extraction. So despite having fractured lead, she was old. So we felt, it was felt that putting a single coil lead and capping the old lead would be enough for her. 8 months later, however, she developed bacteremia related to a dialysis access infection and had lead vegetation. At that time, it was decided that the only solution is really to extract her with endocarditis. And she had an extraction done in the hybrid OR. She had, unfortunately, an SVCRA tear. There was urgent rescue surgery, but the patient expired during surgery. So these cases, this outcome occurred in around 1% or slightly less than 1% of time. But these cases are difficult, and for us here that do extraction before we consider device replacement or device placement, we always think about the long-term consequences of a lead, which is this patient going to need an extraction? What lead should I put in to make it easier? So these two cases illustrate problems with the transvenous ICD. While most acute complications of an ICD are related to the insertion of an endovascular lead, what is as important is the long-term consequences of an implantable transvenous ICD lead. So first, I'll talk briefly about complication of an ICD. Are they common? How common are they? So the first case, the first paper is from a nationwide cohort in Denmark. There were 4,000 implants in Denmark, and if you look at the rate of major complication, it's around 6%. Total complication, 9.9%. So this is not a trivial procedure. Most of the major complications are related to lead reintervention, and 1.8% are pneumothorax and cardiac perforation. Well, you can say this is a European study, but really in the US we don't do much better. And this is a large study from the NCDR database. This involved more than 30,000 Medicare patients who received ICDs. And there was around 11% complication rate. And if you look at the complication, some patients had 1, 2, or 3 more complications. But anytime you had a complication, the cost, the hospitalization cost, increased by around 20%, if not more. And if you look at the complication for single lead ICD, they are mainly lead related, 4.8% mechanical complication, some 1% pneumo, and 0.3% pericardial effusion and tamponade, and some death. So we discussed the short or the acute term complication of an ICD. What about the long-term consequences of transvenous defibrillator? These lead fail, and failure occur more commonly in active young patients or in patients with longer life expectancy who expose the leads to greater cumulative physical stress. And longer living ICD patients, like patients with channelopathy, may also undergo several generator exchanges, each with an associated risk of pocket infection that could reach up to 3%. This is the largest study looking at defibrillator leads. And you can see there's around 1,000 ICD lead followed for more than 8 years. And you can see by year 8, around 40% of lead had some kind of problem. So the rate is really high. And if you look at the annual rate of defibrillator lead defects versus time after lead implant, you can tell the lead that survived to year 10, there's 20% lead failure. So this is very high. Physician identified a problem with the transvenous lead, and there was some attempt to avoid the use of an endovascular defibrillating system, especially in pediatric patients or patients with difficult or absent venous access and patients at high risk of bacteremia. So for example, you could have a pediatric or congenital heart disease patient who have an epicardial pacing lead or an endovascular lead with an occluded subclavian vein. So this case report used this lead for sensing, but put a subcutaneous coil for defibrillation. So they didn't end up putting transvenous lead. But still, this was not purely and completely subcutaneous defibrillator, until the subcutaneous defibrillator was designed. And the person behind its design is Gus Bardi, who's an electrophysiologist in Chicago. And this is really a simple system. It's a large generator that's placed between the anterior and the posterior axillary line at the level of the 4th and 5th rib. And then there's a lead tunneled under the skin to be placed parallel to the sternum. This lead has a coil, which is used for defibrillation, and 2 electrodes for sensing, one here and one here. And the sole purpose of this defibrillator is really just to shock patients from VF. It doesn't have all the bells and whistles of a transvenous ICD. And if you look at this defibrillator, it delivers a maximum of 80 joule and provides only 30 seconds of post-shock pacing. It doesn't do any backup pacing. And this defibrillator, because it has to deliver 80 joule as opposed to 35 or 40 joule from a transvenous device, it had to be bigger. So the size is almost twice. And if you look at the newer generation, even though it's thinner, it's a little bit taller. So this is the newer generation, this is the older generation. And this is one of our patients that was implanted. You see on a lateral X-ray that the heart is sandwiched between the coil and the defibrillator. That's to be able to defibrillate the LV and the RV. And you use three kind of different vectors for sensing, from the proximal electrode to the subcutaneous generator, from the distal electrode to the subcutaneous generator, or you could use this vector for sensing. So you could use any of those vectors depending which one is the best and which one avoid inappropriate shocks. So having talked about defibrillators and how they progressed from large devices to smaller devices and devices that are able to do more, there was actually this nice quote by a well-known electrophysiologist that the subcutaneous ICD represents something of a throwback, as it appears to contradict the constant evolutionary course of technology in which more features and capabilities are packed into increasingly small spaces with each subsequent generator of technology. Because this is, suddenly we had a small ICD and then the newer one is much larger and can do less. So these devices, they started putting them in New Zealand, where it's actually easier to do clinical trial, apparently. And up till 2009, well, the results of the European trial was published, and based on the results of this trial, this device obtained CE mark, which is the FDA equivalent in Europe. And it was approved in Europe in 2009. And this was the seminal paper by Bardi and his colleagues. Bardi is the guy who invented the subcutaneous ICD. And when you read this paper, it's really difficult to navigate because it's really a combination of three different papers in one manuscript. The first paper was, they took 78 patients in New Zealand, and they tried to see which configuration would provide the best sensing and defibrillation. And they came up that this configuration, where the generator is positioned laterally and the coil is parasternally located, provide the best option for sensing and defibrillation. All the other configuration did not work as well. And then they took 49 consecutive patients who received both the transvenous ICD and the subcutaneous ICD. This will be difficult to pass by our IRB, I think, in the US. And they tested this defibrillator. And then at the end, they removed the subcutaneous ICD and left them with a transvenous ICD. So they wanted to see if the subcutaneous ICD could perform as well as the transvenous ICD. And you could tell that both devices were successful in eliminating VF. The subcutaneous ICD had higher defibrillation threshold. And that's expected because it's an external device, not an internal. It doesn't have any internal component. And you can see that the mean DFT in the transvenous system is 11, and the subcutaneous system is 36. And remember, the subcutaneous ICD can deliver up to 80 joule. This device can deliver up to 35 joule. So still a little bit better of a safety margin with the transvenous ICD. And then they published the result of their European trial, which included 55 consecutive patients. So it's amazing how in Europe you get approval based on a very much smaller study than the US. They're not as strict in terms of their regulation. And basically the results of this study were encouraging as a first study. 53 patients had DFT testing, so they induced VF. Upon induction, all VF episodes were appropriately detected. 52 out of 53 patients had 2 successful consecutive DFT. In the old days, devices used to be tested twice and 3 times because this is a probabilistic phenomenon, so you have to make sure it will work every time. And 1 patient had the first 65 joule successful, failed the second 65 joule, but ended up having an 80 joule successful shock. So for us who, like maybe me and Mike, who were not part of the original ICD trials, this is very long to deliver a shock because with the transvenous ICDs probably take around 5 to 6 seconds, maybe 8 seconds to deliver a shock. With the subcutaneous ICD, around 14 seconds. Implant time was really less than an hour. Majority of the time, you don't use fluoroscopy. During follow-up, 12 patients had VT and VF episode, all successfully treated. There was 2 pocket infections and 4 lead revisions. At the original implant, the lead was not tied to the fascia, and then they redesigned the surgical procedure and Now all leads are tied to the fascia, and this lead migration is very rare right now. So after the CE mark, 2 or 3 years later, the early European experience started coming out, and there were two big trials, one from a large Dutch cohort and one from the United Kingdom. There were more than 200 patients between those two trials, 118 in Netherlands and 111 in United Kingdom. One impressive thing about these two databases is that the mean age in the UK, or the median age, was 33. Tells you that physicians were giving this device to younger people. And the mean age in the Dutch cohort is 50, so much lower than the transvenous ICD, where you see trials where you see the mean age in the mid-60s. To summarize the results of these two early European experience, this device was effective but had high rate of inappropriate shocks. There were 100% termination of spontaneous VT and VF. There was one patient who died from asystole after the shock from VF. I'll show you this electrogram. 13 to 15% experience inappropriate shocks, which is high. And unlike the transvenous ICD, where the most common cause of inappropriate shock is AFib with RVR or SVT, in this device, T-wave oversensing is the #1 cause of inappropriate shocks. This was overcome by appropriate device programming in the majority of patients, where you simply change the vector from one out of the 3 available vectors for sensing. And like any new technology, experience reduces complication and improve performance. This is from the Dutch cohort. After the first 15 implants, you can see the rate of inappropriate shocks decrease significantly, and the rate of complication decrease even though it didn't reach statistical significance. This is an example from a patient who had VF, was shocked. You see some kind of an indioventricular rhythm or slow escape rhythm. Then you have asystole and another VF and shock and asystole. This patient had Loeffler syndrome, had, I think, ascaris lumbricoid infiltrating the myocardium and massive eosinophilic syndrome. So this could be one of those that really has end-stage cardiomyopathy, and even if you have an ICD, it's not going to save you, but you could argue, well, if the ICD have more pacing function, it could have saved the patient. It's really unknown. So then, after that, the US IDE trial was started around 2010. The first results came out in 2012, and the publication came out in 2013. Emory performed well in this trial. You see Angel's name on the paper. This was 321 patients who underwent implant procedure. Again, you rarely use fluoroscopy. No electrode or pulse generator movement in 99% of implanted patients throughout the follow-up period. All acute VF induction were detected and terminated. All episodes during follow-up converted successfully with an 80 joule shock. An important lesson from this trial, there was a lot of concerns that, well, if you don't have ATP, then you're eliminating anti-tachycardia pacing as a treatment strategy for VT. But it looks like, since this device takes around 14 seconds to shock you, 60% of VT, by the time they are identified and the device is about to shock, terminates on their own without any reported syncope in the trial. And this is actually seen in some of the newer transvenous ICD. The MADE-IT RIT trial was a New England Journal paper looking at different programming features to reduce inappropriate shocks. And they had the delayed therapy group. This is basically a group who will have VT or VF, and you give it time before you get a shock. And while this group had lower rate of inappropriate therapy as expected, what's interesting is if you're programmed in the conventional group, 22% of patients receive ATP for VT. If you're programmed in the delayed therapy, only 4% receive ATP for VT, which means delayed therapy, you could compare it to subcutaneous ICD, reduce the need for anti-tachycardia pacing. But this is one of the weaknesses of the subcutaneous ICD, that it doesn't provide anti-tachycardia pacing. Again, the IDE trial showed that the device is effective, but it showed that there's 13% incidence of inappropriate shock compared to 4% with the MADE-IT RIT, which is now the way we program transvenous ICDs. After the IDE trial, more European results came out, and this is the effortless subcutaneous ICD registry, which included more than 400 patients, a total of 450 patients who received subcutaneous ICD and followed in Europe. Again, there were 7% of patients who experienced VT and had appropriate therapy. All therapy were successful, indicating that the device is effective in terminating VT, even when the VT occurs as part of a VT storm. But the common features to all these S-ICD trials is the rate of inappropriate shocks. If you remember what I told you about the rate of inappropriate shocks was around 13 to 15%. With the newer programming, 7% of patients experience inappropriate therapy, which is still higher than the transvenous ICD, but not as high as the older study. And another important feature of the subcutaneous ICD, it's good at discriminating SVT from VT, but it's very bad at discriminating T-wave oversensing. The majority of inappropriate shocks are related to T-wave oversensing. The reason the US trial had much larger rates of inappropriate shock is that the European identified if you program this subcutaneous ICD with a dual zone programming rather than a single zone, the rate of inappropriate shocks for T-wave oversensing is reduced by more than 50%, and the rate of inappropriate shocks for SVT is reduced by 70%. So there is room for improvement simply by programming the device to a dual zone as opposed to a single zone. So another trial came out, and this is basically combining the IDE and the effortless registry. And these were more than 800 patients followed up for around 2 years, a little bit less than 2 years. And if you look at the complications, it's clear that it decreases with experience. If you look at implants, they were divided into 4 quartiles. If you look at the infection rate, decreased from 2.3% to around 1.5%. Incidence of type 1 to 3 complication also decreased to less than 6%. The graph in red represents inappropriate shocks, and you could tell that the rate of inappropriate shock decreased with time, simply because dual zone programming or single zone programming was very low by the time physicians were aware that dual zone reduced rates of inappropriate shocks. And over a follow-up of around 3 years, long-term safety and efficacy was at 90% or 88%, which is very good. And this is to stress the importance of dual zone programming as opposed to single zone that reduce rates of inappropriate shocks. So having heard about all the data that's available to date about the subcutaneous ICD, what are the pros and the cons of subcutaneous ICDs? The most common advantage of the subcutaneous ICD is that it eliminates most acute procedural complications that are related to the transvenous ICD, pneumothorax, pericardial effusion, and lead migration. But as importantly, it eliminates the long-term risk associated with indwelling transvenous leads, such as lead failure, the risk of lead extraction that could be needed in the future, or lead-related endocarditis. The biggest disadvantage is the lack of anti-tachycardia pacing, lack of bradycardia pacing, battery longevity. The original device had 5-year battery longevity. The next generation device, which just came out a few months ago, is 7 years battery longevity. Now, single lead ICDs are anywhere between 8 and 9. Some company claim 10. And obviously, T-wave oversensing. And if you look at the transvenous ICD compared to the subcutaneous ICD, really ATP functionality and pacing, smaller pulse generator, better battery longevity, and the ability to deliver CRT are the main advantages over the subcutaneous ICD. But you have the other advantages of the S-ICD that we just mentioned. And to summarize all the trial, if you look from the original trial till the latest trial, which included more than 800 patients, you can see that the rate of inappropriate shocks clustered around 10 to 15% originally. Now with the newer trial, 7 to 3%. If you look at infection rates, they decreased from 3.5% to 1.5%. So there's improvement with the experience. But T-wave oversensing remained the major drawback of subcutaneous ICD. This is one of our patients who was exercising and got shocked, and you can see there's a lot of T-wave oversensing, and patient received the shock here. So we decided to look at our group and to see what is the rate of T-wave oversensing in patients with subcutaneous ICD. At that time, we had 92 patients. The rate of T-wave oversensing was 6.5%. Young patients with preserved ejection fraction were the major risk factors for T-wave oversensing. And these are the same people you would think would qualify best for a subcutaneous ICD. Younger patient, channelopathy patient. And this is not unusual because even with a transvenous ICD, younger patients more likely to have inappropriate shocks, mainly due to sinus tachycardia and sometimes T-wave oversensing. So we wanted also to look at EKG to see if there's any EKG feature that predicts T-wave oversensing. And if you remember the sensing vector, the primary, secondary, and alternate, and you compare them to the Einthoven triangle, you can see that the alternate is equivalent to lead AVF, and the primary is equivalent to lead 1, and the alternate is equivalent to lead 2. So we looked at lead 1, lead 2, and lead AVF, and we saw that the QRS amplitude in lead 1 predicted T-wave oversensing. That's because the subcutaneous ICD really relies on the QRS to T-wave ratio. The bigger the T-wave and the smaller the QRS, the more likely the T-wave oversensing. Turned out the QRS amplitude in patients who got T-wave oversensing was less than half of the QRS amplitude in the control group. So that might be a quick way to screen your patients when you offer them a subcutaneous ICD to know who's more likely to receive T-wave, inappropriate shocks for T-wave oversensing. So who should and who should not get a subcutaneous ICD? I think in our EP group, we're more likely to offer subcutaneous ICD to young and active patients, patients with indwelling catheters, immunocompromised patient with channelopathies. These patients are usually young, have preserved ejection fraction. They're more likely to live longer, acknowledging the higher risk of T-wave oversensing. Obviously, any patient who had monomorphic VT probably should get a transvenous ICD. When patient need pacing, he should get a transvenous ICD. Sorry. When you have patient at high risk of VT, such as patient with sarcoidosis or ARVD, these patients more likely to have VT than VF, probably should get a transvenous ICD. This is not the case anymore because newer subcutaneous ICD have the ability for remote monitoring. And this is what was seen in the original real-world experience. If you look at the mean age of these patients who got subcutaneous ICD, you see it varies between 20 and 50. So physicians or implanters who implant subcutaneous ICD identified that younger patients are the one who should get the subcutaneous ICD. Another important group of patients that might benefit from subcutaneous ICD are patients on dialysis. You could argue, well, patients on dialysis were never included in any trials of ICD trials, but these are patients we see in a clinic, and fortunately or unfortunately, we have a large population of dialysis patients at Emory. And this is data from the Emory system. The Faisal Immersion presented this last year, Heart Rhythm, looking at more than 3,000 ICD patients followed over several years, and we had 5% incidence of dialysis patients. So that's a large percentage of our patients who receive ICD are actually dialysis patients. And you could see it's, as you would expect, mortality of this group is higher than the patients not on dialysis. And as the literature shows, a large proportion of mortality in these dialysis patients is infection. So you would think that subcutaneous ICD would work well in patients on dialysis. There was some theoretical concern because patients on dialysis are more likely to have electrolyte shifts, and if they miss their dialysis, the T-wave amplitude could increase and they could receive an inappropriate shock. So we decided to look at our data here on patients on dialysis who received the subcutaneous ICD, and this was the first report of subcutaneous ICD in dialysis patients. We had 27 end-stage renal disease patients who received a subcutaneous ICD. While this is a small number, this is the only report in the literature up till recently. And we looked at the risk of infection and risk of inappropriate shock. Surprisingly, and again, this is a small number, we had 0 infection in dialysis patient. And the risk of inappropriate shock, the annual event rate, was similar between dialysis and non-dialysis patients. And since this cohort is sicker, the rate of appropriate shock was much higher in the non-dialysis patient. So 18% almost had shock for VT and VF versus 1.4% in the non-dialysis cohort. But the risk of inappropriate shock is similar, and the risk of infection was very low. So what about the majority of patients referred for primary prevention ICD? Obviously, if you have patients with an absent venous access, patients who are prone to infection, young patients, we're more likely in our group to offer them subcutaneous ICD. If you have patients who have VT, require pacing, require CRT, then transvenous ICD is the way to go. What about the majority of the other patients? What should they get? And there's a lot of early adopters and there's a lot of skeptic in the EP world. And I thought this was a good editorial in JACC in 2012 prior to the FDA approval. Dr. Hauser is a physician in Minnesota and who's very well known for criticizing device company appropriately. Anytime there's a recall, there's a lot of criticism. And he acknowledges that the S-ICD is a promising technology, but at the same time, he mentioned that it's a new technology and as such requires the scrutiny of a comparative effectiveness trial. Only then can we tell patients that it is as effective as existing ICDs. Otherwise, a fully informed patient who's offered this device today should not want one. This was a little bit of a harsh editorial, but he has a point. You can see his point that you need comparative studies. Up till now, we have no comparative study, and the only comparative study we have was a case control study. And this was a multi-center study looking at 69 subcutaneous ICD compared to 69 control patients from multiple sites who received transvenous ICD. And this is a table of adverse events, which you look in both is very low. This graph might illustrate it better. If you look at induced VF conversion rate from the first shock, it's similar. If you look at inappropriate shocks, it's higher in the S-ICD, but did not reach statistical significance, 7 versus 4%. The peri-procedural adverse events, which included pneumo and pericardial effusion, was expectedly higher in the transvenous ICD, again, didn't reach statistical significance, and the follow-up adverse events was similar. So at least in this trial, they appear similar. So the S-ICD trials reviewed today show that it is a reliable alternative to the transvenous ICD. It is effective in defibrillating VT and VF. Its sensing algorithm is very good in discriminating SVT from VT, but it's very bad in discriminating T-wave oversensing. And the Praetorian study will better define the role of the S-ICD as compared to the transvenous ICD. This was an investigator-initiated study from the Netherlands that started in Europe, already enrolled 600 patients. Recently, they decided to add US studies and US centers, and Emory is a center, and looking to enroll around 850 patients, follow-up for a median of 3 years. So I think this study will be able to tell us whether the risk of inappropriate shock would be equivalent to the acute complication risk of a transvenous ICD, and what's the difference between the inappropriate shocks between the S-ICD and the transvenous ICD. So in conclusion, the clinical experience from the introduction of S-ICD system underscores its role as a reliable alternative for prevention of sudden cardiac death. The exclusive use of a subcutaneous lead for sensing and defibrillation represent the greatest advantage of this novel technology. The lack of demand bradycardia or antitachycardia pacing limits its utility in patients with conduction system disease or paced terminable VT. T-wave oversensing remains its major drawback. And as seen with other early examples of evolutionary technology, improvement in design and manufacture will probably improve upon some of the drawbacks of a first-generation device and probably will lead to more widespread adoption. Thank you. This is my acknowledgement slide. Basically, I'd like to thank the entire EP team, mainly Faisal Mershin, who's been a great addition, and he's really a statistics guru. And Paige Smith and the entire EP research team. Thank you.
Thanks, that's fantastic. It drives home how valuable our EP team is here and what the great work you guys are all doing. I'll give you one question. So it seems like when you show the data about the pacing terminated VT, that I guess a lot of that we're terminating and feeling good about, we don't need to feel good about because it would have gone away anyway, I guess. Is that one of the sort of surprises of this?
Yes, and that's actually was known from the earlier trial, that you see the mortality reduction with a defibrillator is way lower than the amount of VT or VF therapy that you get. And it looks like we programmed these devices very aggressively to treat episodes that do not need to be treated. As we've seen in the MADE-IT RIT, from 22% VT of patients requiring ATP down to 4% requiring ATP. And the interesting thing about the MADE-IT RIT, there was no increase in syncope episodes, because you would worry if you leave VT untreated and sustained for a little bit, you will have higher incidence of syncope, and that was not seen. But that's obviously a concern that a lot of people had.
I guess my only question is with the delayed intervention by the ICD, do you see more VF?
It is possible. It is one way. A lot of the time when we put ICDs, transvenous ICD, we program it with a single zone above 200. And the assumption, if you have VT that's left untreated for a long time, it will either terminate or degenerate into VF and receive treatment. It doesn't look like the incidence of VF increase, but at least we know that the majority of these VT or slower VT terminates, at least more than half.
The patients who are hypertrophs are, a group that end up with ICDs frequently.
Yeah.
Are there EKG
Yes.
peculiarities a problem in T-wave oversensing?
That's a very good question. Hypertrophic cardiomyopathy patients, usually younger, have preserved ejection fraction. Most of the time, they do not need pacing. So this subcutaneous ICD in this group of patients was used extensively, mainly in Europe. There's multiple trials focusing on this group. And the rate of T-wave oversensing is much higher than control group, simply because of the T-wave amplitude compared to the QRS. It's maybe close to 10% in this group. Dr. Smith, sorry, he's been waiting.
Just a comment about, we talk about patients with low ejection fractions who have end-stage renal disease, and I think it's important to remember that end-stage renal disease causes a cardiomyopathy,
Yeah.
and it's a reversible form of cardiomyopathy that can reverse with kidney transplantation. And generally, the left ventricle is not markedly dilated. It's usually just normal size or a little bit dilated, but the ejection fraction is low. And as you mentioned, there's really no data for defibrillators in patients with end-stage renal disease. They were excluded from the trial. So just one word of caution that we don't jump to the conclusion that we just move to external devices, subcutaneous devices.
Yeah.
We really need to consider, has the patient been referred for kidney transplant? It turns out that Georgia has the lowest referral rate
Yeah.
in the country for renal transplantation, but it's certainly something to keep in mind. Now, that's going to be different from a patient who's had a myocardial infarction, has a low ejection fraction, is on dialysis, and the question in those patients might be, what is their prognosis anyway? Because generally they have a pretty poor prognosis overall.
It's a good comment. Agree. Dr. Guy.
I also thought when you showed the dialysis patient, a 7 So the a 17% rate of appropriate shocks per year seems like that means that you're underutilizing ICDs in dialysis patients. When it's 5% in other patients and it's 17% in the dialysis patients, it seems like your indications might be extended to higher ejection fractions in dialysis patients.
Yeah, and that's a good question. There's always the competing arrhythmic risk versus the non-arrhythmic risk. And unfortunately, with dialysis patients, they do have higher rate of arrhythmia, but they also have higher rate of infection and multiple other strokes. So we don't know really, because there's not been a single trial that showed ICD improved survival, but yeah, they do have higher incidence of VT and VF.
Mike, what's the cost differential between the venous and the other pacemaker?
Yeah, I honestly don't know. It is more expensive, but and the reimbursement is less. So like any new technology, you know, we talk about Watchman, we talk about the Micra leadless pacemaker, you know, Mike talked last week. They are more expensive, and unfortunately, reimbursement originally is less. I don't know what's going to happen down as it become more widely adopted. And if the head-to-head comparison study shown benefit of a transvenous ICD, you know, maybe less infection, less endocarditis, because not a single subcutaneous ICD infection up to date have been associated with endocarditis. If that could be proven as beneficial, maybe the reimbursement will be better. But so far, with any new technology, reimbursement is less, cost is more.
So a comment and a question. Well, obviously the shocking part is pretty much solved. I mean, it's the sensing part that's really the difficulty. And I was noticing that in your first study, the engineer there was Robert Fischel, who has developed a lot of things, including big companies in this. And he has one little company that's called Angel Medical. They may have changed the name of it, but it was to detect ST shift, to detect early onset of myocardial infarction. I don't know what's happened to this in subsequent years. But the question has to do with this trial that's coming up, and it sounds like it's sort of a non-inferiority trial compared to the implantable. And so when that's all over and said and done, is Dr. Hauser going to be satisfied? He's going to write another editorial about you ought not to use these things, so this has to do with beyond this subject. But I love randomized trials. But I mean, you're going to do an 800-patient, very expensive randomized trial where the technology is not really quite where you want it to be. I mean, I guess people are trying to fine-tune this technology, but seems like the sensing thing is going to remain a problem even after that trial.
Yeah, I think it reminds me a little bit of stent versus cabbage. And, you know, you do a trial and then you say there's a new stent that doesn't restenoze. And so maybe, but again, this is a technology that's present. And at least if you're going to use it, it'll be good to have somehow for randomization to see if it's equivalent. My guess is the rate of inappropriate shocks will be higher, but the rate of complications, other complications, including infection, endocarditis, and pneumothorax, pericardial effusion would be lower. And then you'll make an informed decision, a better informed decision with patients when they get referred to you. Tell them you get this, even though you might have a little bit higher chance of T-wave oversensing, you might have lower chance of endocarditis, pneumothorax. So in that sense, a comparative head-to-head trial is useful.
When we first started pacing here at Emory, it was with epicardial leads from a subxiphoid approach. Could you not do some minimally invasive epicardial lead placement that?
Yeah, they've been designed mainly for LV pacing. I think Mike put one once for patients who didn't have a CS or had difficult CS. I think in my mind, doing it for an ICD, like if you have the same problem, if you have an infection after generator exchange, then you're dealing with an infected epicardial system, which is even harder to deal with than an endovascular infected system. But that might improve sensing. One thing I didn't talk about is the company is coming up with a new technology and new trial, like Mike talked about last week, is combining the subcutaneous ICD with a leadless pacemaker, the Micra, so they can crosstalk and sensing will improve, and with the ability to deliver anti-tachycardia pacing. So that might be a way to get over it.
You have a comment from Angel, who's been trying to speak, but we haven't let him. He said the whole ATP thing is controversial. No one's proven a survival benefit. If anything, it provides opportunity for error. Made it RIT, prove turning it off is actually best. The more complex we make these devices or program, it seems like the worse results. And inappropriate shocks may really reflect the population implanted. So,
I agree. I agree with my boss.
Okay.
All right.
With that, thanks so much.
Thank
Michael.
you.
That was fantastic.
Thanks.
The preceding program is copyrighted by Emory University.